Hello everybody and welcome back to my vlog. So this week's another one for the ladies, I'm afraid. Sorry men out there. But we are important and we have been neglected for a long time. I'm going to cover menorrhagia this week. Menorrhagia is one of those posh medical words for heavy periods, which may not sound like a medical problem, but for some people it really is. So it is subjective. It is something that needs to be judged by the person who's suffering and how it's making them feel and how it's interfering with their life. There is a definition for menorrhagia, and that is that somebody who has more than 80 mils of blood loss during a period when the average blood loss is 30 to 40 mils. That's obviously quite hard to judge. If a period lasts for longer than 7 days, or if you've got both of those things. So that's the official definition of menorrhagia. But I would say that when I see women, what's important is how often they're changing their sanitary towels or pads or tampons. Is it every hour? Are they bleeding through their clothes or into their bed at night? Do they need more than one type of sanitary product? So a tampon, for example, plus a towel, and all of them super absorbent. And is it more than the woman that is sitting in front of me can reasonably manage in her day-to-day life? I think that's a more reasonable definition. So it's common, that's the important thing to know, and for some women it's absolutely debilitating. And it's quite often there isn't an underlying cause, it's just the pattern of bleeding for that woman. But that doesn't mean we shouldn't take it seriously or treat it. So who suffers? Obviously women. 30% of women report heavy periods, so that's 3 in 10. As I've said, it's subjective because one woman's definition of a heavy period may be different to the next. The prevalence is about 9 to 14% when you actually measure that menstrual loss, so when you take into account that definition of 80 mils or over. And as I've said, that's difficult to do. 1 in 20 women aged between 30 and 39 consult their GP every single year for heavy periods or other menstrual disorders. So it's a big problem. And menstrual disorders are the second most common reason that a GP refers a woman into secondary care to see a gynaecologist. In fact, 12% of all gynecological referrals. So why is it important? Well, as I've said, it's debilitating. It stops people doing normal things. So it stops social activity, so sport, social events, going to work. And so it's really important. It causes anemia, and anemia is dangerous when it's really bad. It causes tiredness. It stops women looking after their children, their husbands, themselves. It's embarrassing. Bleeding through your clothes when you're at work or in a supermarket or anywhere is embarrassing. And for some women, it causes depression, and I completely understand that. So what causes heavy periods? Well, as I've already said, in 50% of cases there is no underlying cause, but there are some things that do cause it. So things like endometrial polyps, pelvic inflammatory disease, fibroids, endometriosis, which is more associated with pain but can cause heavy bleeding, adenomyosis, again more associated with pain but can cause heavy bleeding, polycystic ovarian syndrome, because a woman goes for months without a period and when she does bleed it can be very heavy. Endometrial cancer, blood clotting disorders like von Willebrand's disease, liver or kidney disease, obesity, probably because when people are obese they produce more hormone, more estrogen, which causes the lining of the womb to build up more. Diabetes, certain medications, so blood thinning drugs, chemotherapy drugs, they can all cause excessive bleeding. Intrauterine devices like the copper coil causes more painful and heavier periods for some women. Some herbal supplements that women take for women's problems, ironically, can cause excessive bleeding. So there are lots of causes, and some of them can obviously be treated, but some can't. So then we have to look at the overall diagnosis. How do we go about diagnosing a woman with menorrhagia? So first of all, see your GP. And the GP would take a really good history, when you started your periods, how regular they are, when you bleed, how long you bleed for, how it's interfering with your life, because that's the important thing. They'll take a history of your family, what children you've had, what you're planning for the future in terms of future pregnancies and family. They should do some blood tests to test things that might be causing your bleeding, like thyroid blood tests, a full blood count to make sure you're not anemic, and look at your clotting in some cases if they suspect that's the issue. They should do a physical exam and a speculum, have a look at your cervix and feel your tummy to see if they can feel fibroids, see anything wrong with your cervix, see a polyp, see if there's any pain or any discharge that might indicate pelvic inflammatory disease. They should do swabs for infection, again looking for pelvic inflammatory disease. And an ultrasound scan, because that's the only way to truly look inside the uterus and see if there's any fibroids, any lining problems or anything else going on. So when do they refer you to secondary care, or when do they treat you? So if the GP is trying to treat you, and there are lots of things that we can do to treat you, and it's not working, then we would refer you to gynecology. If you have bleeding in between your periods, which is continuing and we can't find a cause for it, we would refer you. If you're 45 or more and you've suddenly got new onset heavy menstrual bleeding, if there's a history that is suggesting to your GP that you've got something wrong with the lining of your womb, they would refer you. If they do a physical exam that is abnormal, if there are risk factors for you for endometrial cancer or hyperplasia, which is where the lining of the womb builds up, if there's a family history, a previous cancer, or you're on HRT and you're having abnormal bleeding, they will refer you into secondary care. And if you've got iron deficiency anemia, which is not responding to treatment despite every attempt by the GP, then they would also refer you in. But what is the management ladder? Where do we start? So the management's quite simple in that it's divided into two areas: medical treatment or surgical treatment. So let's start with the medical treatment, because your GP can do most of this for you. So the first line gold standard is the Mirena Coil. And I know lots of women don't like the thought of the Mirena Coil, but it does work. It really does work. You get some teething problems, but it's proven to show more improvement in quality of life than any other treatment for menorrhagia, and that improvement is likely to continue. The rate of discontinuation of the Mirena Coil is 16%, so 16 in 100 women at 12 months, and 28% at 24 months. So it's quite high, and there are reasons for that. But it is more effective than oral medication, but it does have more minor side effects than oral medication. So it's about finding the balance and also sometimes working through. It is more cost effective than the surgery. So what happens with Mirena that women don't like? Well, in the first 6 months you can get erratic bleeding, and I know that because it happens to me. When I have my Mirena, I bleed every single day for 6 months and then it stops. So you have to be able to get past that 6 months, and there are tablets that the GP can give you if it's really bothering you to help you get past that. Some women claim that they get hormonal symptoms from the Mirena, so mood changes, acne, and some women get pain, but they're in the minority, and generally if you stick with it, it is the best treatment for menorrhagia. But let's assume you can't, or you want to try other things before you go to the Mirena. So drugs are the first step that GPs can take. Mefenamic acid is one of the first tablets, which inhibits prostaglandin synthesis, and it's prostaglandins that make your uterus contract and cause pain and encourage the bleeding. So if you reduce that with mefenamic acid, you reduce menstrual loss by about 25%, and for some women that's enough. And mefenamic acid is better tolerated than ibuprofen or naproxen, so you should try those first. Then there's tranexamic acid, and this is a plasminogen activator inhibitor, so it changes the way that you clot and that your blood clots. So that reduces blood flow by up to 50%, and it's most effective in women with fibroids and bleeding disorders and who can't tolerate the IUD. Side effects from tranexamic acid include nausea, vomiting, diarrhea, and changes in colour vision. And if you get changes in colour vision, you must see somebody immediately. Then after that, we have ibuprofen or naproxen, the NSAIDs, the combined oral contraceptive pill, which we can now take back to back. So the rules have changed on the combined pill. So now you can take it back to back as long as you don't get any bleeding. So that could be a year, for example, without a period. And if you do get bleeding, you just stop for 4 days and then you start again. So that can be quite effective as well. And so those are the medical treatments. So there's mefenamic acid, tranexamic acid, ibuprofen and naproxen, and the combined oral contraceptive pill. So your GP should be able to do all of those for you. And only if they're not working or you can't tolerate them should they then look at other things or refer you in. So progestogens are the other option, and these are hormones. So you're looking at something like norethistron, 5 milligrams 3 times a day from days 5 to 26 of your cycle. Or a depo-progesterone, so that's an injection that you have every 12 weeks. They do work, but they're less effective than those other methods I've just talked about. They're less acceptable to people because people do get side effects from progesterones, just like the Mirena Coil. And they're really only a short-term solution, because long-term norethistron puts you at higher risk, for example, of blood clots, DVTs. So they're third line. They really are at the back of the cupboard in terms of a treatment. There are some other medical treatments, but I don't think your GP would do this. This would be in secondary care. So there are GnRH analogues for 3 to 4 months, but we generally only use those prior to surgery. So, for example, if you had big fibroids, we would use those to shut down the feed to the fibroids, hopefully let them shrink a little bit before surgery. They put you into a menopause state, so you can't tolerate them for a long time, and they're not good for you for a long time. But if all of the other things I've spoken about can't be used or they're contraindicated for medical reasons, then it is an option that can be used in secondary care. Excuse my voice, as you know, I've just been poorly and I'm still getting over it. And then there's surgery. So after you've tried everything medical, or you can't try medical, then there's surgery. So surgery is more effective, but there's less reversibility, obviously, and there are the complications and risks of surgery, which you get with any surgery. So the first surgery is endometrial ablation. So this is where the lining of your uterus is ablated. So it's a removal of the full thickness of your endometrium and the superficial myometrium behind it and the basal glands. So it really is the entire inner lining of your uterus. It's first line if your uterus is smaller than a 10-week pregnancy when you're examined. It's no good if you've got big fibroids. And there are different methods to doing it. And I won't go through all of the different methods of endometrial ablation today, but they all have the same end result, that you no longer have a lining to your uterus, so you no longer bleed. So that's how the problem is solved. The side effects of endometrial ablation are vaginal discharge, increasing pain or pain that continues, infection, perforation, so a hole in the uterus, loss of fertility, and that's usually what happens after endometrial ablation. So it's an important decision to make. You need to be sure that you've completed your family, because it would be unlikely that you would be able to get pregnant again in the future. However, you still need contraception and progesterone in HRT, just because we never really know how much of the lining is left. Endometrial ablation is an effective alternative to a hysterectomy, so a smaller surgery but as effective for menorrhagia, and it has high satisfaction rates. So it is quite a good solution if you really can't get on with medication and you've had enough, and I understand that. So another surgery is uterine artery embolization or a hysteroscopic myomectomy. So they're two different things. So the uterine artery embolization is to block the arteries feeding the uterus so that you get less blood flow and hopefully less bleeding each month. And the hysteroscopic myomectomy is when the surgeons go in and take away fibroids but leave the uterus intact, and hopefully taking away those fibroids will stop the bleeding when it's fibroids that are causing it. It's good if you've got a uterus that measures more than 10 weeks in size on palpation. So better than ablation when it's that size, because usually it's fibroids that are making it that size. and when you've got a desire to retain fertility, so keep your uterus for a future pregnancy. So you can either cut off the blood flow to the uterus and the fibroids and hope they die, or you can go away and cut out the fibroids. They're quite big surgeries, or certainly the myomectomy is, but for some women, and I have seen it done, it works for them, stops the bleeding in the future and allows them to get pregnant, so it's important. And then finally, for those women who know that they don't want to get pregnant anymore, or they're of an age where they're not likely to get pregnant, a hysterectomy would obviously solve the problem. So a hysterectomy is where you take away the uterus, so there is no more bleeding after that. But because we're taking away the uterus, the family must be complete because you cannot get pregnant afterwards. It's usually used where all other treatments have failed, where we want to make sure there's no more bleeding, so you want amenorrhea. So instead of menorrhagia, you have amenorrhea, no periods, and that there's no need to retain fertility. You need to think about a hysterectomy, so things like recovery time, infection, bleeding, damage to other organs during the surgery, damage to your bladder, so then you have urinary problems, blood clots after the surgery, and of course you will go into surgical menopause, so then you'll need to think about HRT. I won't go on any more about hysterectomy because I've done a vlog about it. So if you want to know more about hysterectomy, what questions to ask your surgeon and what to expect during and after the surgery, I've got a very good vlog on that, so go over and have a look. So in summary, menorrhagia is absolutely debilitating for the women that are suffering it. It is subjective in terms of how much bleeding is too much bleeding, but as far as I'm concerned, if a woman says she's bleeding too much, then she's bleeding too much. And that's the most important definition of menorrhagia. It's a massive cause for lost work days, so it's important to both the woman, her finances, and to the economy. Treatments are available, and they're available from your GP, and for many women just taking one tablet, mefenamic acid, is enough to solve the problem. So the treatments can be quite simple all the way through to surgery and full hysterectomy, but there's a nice ladder and lots of options available. So the most important thing is see your GP. Don't suffer in silence. I did suffer in silence with both pain and bleeding for years because I just thought it was normal for me and something that women should put up with. Gone are those days. You don't have to put up with this, and a good GP will treat you quickly and easily, and you can go back to a normal life, not having to dread your period every single month and take time out from life. So I hope this has helped, I really do. I'll put some information in the comments afterwards as always. I did this particular vlog in response to a request that I got in the comments around the New Year vlog, so please, if you've got subjects that you want me to cover, just pop them in and I will do them as I have today. And thank you as always for subscribing and for taking the time out to watch me. Take care. See you soon.